at 77% of the time, 5 days in advance, we could predict an adverse event.
If you give antibiotic 1 hour early, you decrease the rate of admission in a hospital by 30%.
I actually call it the early versions of a Star Trek tricorder. I mean, we're literally pointing something at you. You're not wearing anything. There's nothing to charge.
Good morning, everyone, and welcome back to Signals and Symptoms podcast. Today we have an amazing guest over here, Dr. Nayan Patel. He has been working on an amazing product, which is essentially what we call contactless vital signs through his company called Neteera.
So my name is Nayan Patel, and hello, Harvey. Hello, Ed. Good to see you all again. We're old friends, so we're longtime acquaintances. Ed and I particularly go way back. I think we've shared many conversations together. Yeah, I've been in healthcare for a number of years. Last 20 have been specifically here in the Dallas area with large healthcare systems like Baylor Scott and White. I was running 2 of their heart hospitals from a CIO standpoint. In January, I joined Neteera. Neteera makes a contactless vitals monitoring system. And what it looks like is this device here. You might be able to kind of see it. It's no bigger than a deck of cards. And essentially it's radar. It's high frequency radar. It's a motion sensor. And it uses fixed radar technology. I have one actually pointed at me right now on a tripod. So it is monitoring my heart rate, my respiratory rate. It detects them by micro movement on your skin. So every human body is electrical and mechanical. And we essentially map an ECG to a BCG. So everybody knows what an ECG is. A BCG is a ballistocardiograph. And essentially we are tracking those micro movements on your skin, through your chest, and basically it goes through clothing and bedding as well. And that's how we are able to map that and accurately track heart rate, respiratory rate, inhale-exhale ratio, and sleep and motion data.
Yeah, number one, I guess the FDA will obviously do that. I'm curious how much of within margin of error are the ranges of the heart rate of all the parameters you're taking in it. I'm just curious.
Yeah. So we actually monitor, we collect the data every second, and then we trend it, and we have a dashboard that we report at every 5 minutes to show kind of where your heart rate is at. It's a 95% accuracy right now, and it's going to be higher than that once you're trending it, right? So, if you're getting it 95%, in 1 minute or 5 minutes, you can imagine the number of data points. We collect thousands of data points that are, because we can detect your heart rate, as an example, through your hand, through your leg, as well as your chest cavity. But one of the specific use cases is somebody passes away in the ED, right, while they're waiting. And so the one hospital approached us specifically and said, hey, could your technology help us with this type of situation? And that's how this use case got created. So we put this device in the chair. We got a medical furniture manufacturer to, build it out, configure it, and now we have these chairs available. And the goal is that if a patient is in the 4 walls of any hospital healthcare system, they feel that they're responsible for that body, right? And so we are working through the logistics on the workflow and the notifications. But essentially, if there's somebody sitting in a chair now and we see their heart rate drop below 50, below 40, whatever, something that says, hey, something's happening to that person's body, we can send an alert to whoever the nearest nurse or nurse call system that's there to, basically escalate a situation, say somebody in that chair needs attention.
Is that of all the things we do in healthcare, blood pressure is the least accurate. And you will not believe like how crazy it is, because we used to do blood pressure through manual cuff. Then there is automation blood pressure cuff. Then there's Artline, and now, of course, your solutions, which including some of these solutions that are coming. So blood pressure has always been a problem. And then, of course, vitals in general is extremely important. And then you need to figure out the trend, because the trend is more important than that. Just to remind you people that we had a study on sepsis. Of course, COVID data really, freaked out, but clinical decision support system modules were released. I was able to detect 15 minutes early, which is insane, that I can actually expectorate a pneumothorax. If you give antibiotic 1 hour early, you decrease the rate of admission in a hospital by 30%. You decrease the rate of ICU admission by 10%. You decrease the rate of death by 1%. So again, I just want to make sure that everyone understand clinically that how important vital monitoring is. And I just want to clarify a few things. We can do pulse ox heart rate monitoring here, but just want to be very careful. They have AFib monitoring, which is a big issue for, a big belly genetics like mine, coming from India, Pakistan, and Nepal, the SAARC countries. The difference is that number one, I cannot sleep with an Apple Watch. That's why I got this, which I can't sleep with it either. I just can't. And then, so we need something that is not touching my body overnight. And that's extremely important. Not to mention that one AFib case detected out of 100, we can now treat it with a medication called apixaban, which is actually equivalent to an aspirin. So long story short, you have a proper pathway moving forward of detecting it. And not to mention, of course, that overall costs, if the patient gets a stroke or a cardiac myopathy or anything, millions of dollars downstream can be saved by early detection. Not to mention, how do you push that information in as well, rather than just another dashboard for me to review? Do you understand what the problem is? Then I already have freaking alarm fatigue. I'm not gonna oh my God, now I have to check another system. Do you
One for you first, because as a CIO for hospitals, that's the first thing that I said. Listen, our dashboard is great. You need it for setup, but beyond that, that's it. The rest should be the alerting communication should be with whatever the system currently uses, a nurse call system of some sort, right? Most things are using some version of RAW and Responder 5 or whatever it might be. We're ready. Home health is the next target market. Everybody asked me, and I had the same question, honestly, when I was going through the interview process. I said, hey, can I use this for my mother-in-law? Right? She's in an apartment by herself, senior living. She's not in assisted care or any kind of real monitoring, right? So, and she didn't want a camera in her house. So that's the best thing about this thing. There's no privacy issues with this thing too. There's no data, there's no visual or audio data being collected of any kind.
I just want to clarify for the audience, there are people who are actually calling the camera, and then they're on the telemedicine, they're trying to report a lot of shit. By the way, just to let you know, this is all garbage. There is really no real camera technology. I have tested it. People are saying they're going to use it for phone cameras for vitals. Does not work. Just be careful with it. And I completely agree with you. As a clinician, I'm backing you up with that claim. I just everyone to understand that limitation. Maybe it's going to go away. Maybe we're going to have LiDARs on the phones, which, by the way, LiDAR is essentially a radar.
We've got over 40,000 devices deployed in long-term care facilities or skilled nursing facilities, or SNFs, right? We did an efficacy study for 4 months monitoring 612 patients that were in the bed. And what it produced was that 77% of the time, 5 days in advance, we could predict an adverse event happening. So because of the trending data, we're collecting all this data and we see what they're...
We have screening devices, then we have verification devices, which is your technology, also on top of that. And then before I even call the patient to the ED, urgent care, or the hospital for an admission, where do you see evolution of ultrasound, home-based ultrasound? By the way, there are now robots who can just do whole echocardiogram. through ultrasound, and as an evolution of what we call a monitoring spectrum and paradigm, from screening to verification to localization to pathways like admissions or further, CTA, heart, or whatever, imaging, etc. So where do you place ultrasound in there?
Yeah, no, I think it's one more piece of the puzzle, right? I mean, we talked about, or I mentioned it earlier, when you think of the Star Trek tricorder, we all remember this. Like you just point it and it does this whole full body scan and it gives you all kinds of information. So it's one more piece that, if we can implement that technology, and we'll continue to get better and better, right? We're going to be able to find different things that our technology will do, and it may supplement, ultrasound too, because again, I can't speak too much about ultrasound. I'm not an expert in there, but I understand the core concept behind it, right? I mean,
Texas especially, I believe that the individual owns the data. So, I mean, it's not black. Yeah, everyone should own their own data. So, I mean, if you had to pick one, that's my pick. Obviously, there's nuances like you talked about, Junaid, where you're using your IP, your technology, so why should someone else benefit? But ultimately, at the end of the day, we all know the key. I love monitoring. I love everything we talk about. But at the end of the day, the biggest difference maker is the personal decisions people make on a daily basis.
yeah, I think over the years, that's definitely been a challenge. The magic question, I mean, that question is asked all the time: who owns the data? And there's just never been one right answer that can be put out, because there's so many different scenarios of the types of data that's out there, right? I mean, if you have any issue of any kind, you're visiting multiple organizations, multiple systems, multiple vendors could be involved, and there's data going in different.
I work for a space company, Phantom Space. We are working on cloud data centers in space. Now think about that. If I could give everyone your data on your phone, and now give you a direct access to a data center, not OpenAI, nothing AI, it's where it's doing edge computing and processing and coming back. Think of all the possibilities of what he's doing. And then to answer your question on the digital twin, who owns that data? If we can create some kind of blockchain system that allows you to keep it on your device, process somewhere else, come back down, now we've created this independence that we're wanting. Number two, as far as what the future holds, the nice thing is many companies are doing this progress, and I'm really anxious to see what the Dubai area is doing, the Middle East and Singapore, because they're really pushing hard on this, creating digital twins, putting it inside your EMR so that it's already one platform and it's being pushed down from the government to one all the way down. What I see coming in the future, I love voice biomarkers. I think that is going to hit hard, and I'm really excited. I'm actually looking at training some of my own data so I can come up with my own algorithms, because I think that'll be fun. But big picture, the one thing I want to say, it's all about the patient. What can we do to help that person? And if we can save lives and create the thing where we're preventing things before they actually happen, we have made an impact in humanity.